quite well.
I think we have people back on, and we have a bunch of people here in the RCC, so you can start whenever you're ready.
Okay. All right. Then yeah, let's do it. Okay. So this is again something I think you could be asked. So you get a patient, and it's something you don't want to miss clinically. So severe retrosternal chest pain, worse with swallowing, so adynophagia, and a left-sided pleural effusion. And I missed this question, and because I was looking for the subcutaneous emphysema. So this is Borhave's, or an esophageal rupture. And again, typically you'll have, I've seen a few of these, and they'll have crepitus if you kind of palpate along their sternum, and especially like at the clavicle near where it meets your sternum, you can feel like little snap, crackle, pop. And that's, obviously pretty concerning for this. But again, I had a question on my boards like this. I think the patient was retching. They don't give you anything obvious like, oh, they recently had an EGD with dilation or subcutaneous emphysema. They didn't give you anything obvious like that. It was just this left-sided pleural effusion, which I did not really know about before taking the test. So watch out for that. Chest pain in this isolated left-sided pleural effusion. They're trying to get at a esophageal rupture. And the next best test is a gastrographin esophagram, right? You don't want to do barium because, that's more toxic to your tissue if it gets out into your mediastinum or your peritoneal cavity. So this gastrographin is much more benign. So gastrographin esophagram. And then, if once you come up with this diagnosis, usually with CT imaging, it's empiric antibiotics and cardiothoracic surgery. Okay, so here's another really rare thing that I've never seen before, but they like to ask test questions about it. Epigastric pain, weakness, weight loss, which are not specific. The thing with this is they'll have a low albumin, and then they'll usually give you that they're not losing it through their urine. And then EGD will show this like significantly enlarged rugae. So if you look on the right there, it's, that looks abnormal when compared to a stomach on the left that's been insufflated with air on EGD. And this is something called Menetrier disease. So again, very rare. It is associated with gastric adenocarcinoma, and it's a mutation where you get this increased tissue growth factor alpha, and it leads to a protein loss enteropathy. And the treatment is you really just high protein diet. They do have monoclonal antibodies against some of these like EGFR that have been used in more palliation. But I don't think they'd ask you a treatment question with this because it's so rare, and usually these patients need gastrectomy, and they don't do well. But if they gave you some sort of protein loss enteropathy and the abnormal rugae, they might ask you for this Menetrier's or maybe increased TGF alpha. It'd be a tough question, but it always comes up in board review, even though, like I said, I've never seen it. And then also to be aware, Zollinger-Ellison, another really rare thing they like to ask questions about that we'll talk a little bit more later. It can also have these large gastric rugae. So don't associate the Menetrier's just with the large rugae. They have to have that protein loss enteropathy along with it to be diagnostic. Okay, so a little bit on H. pylori. It's gram-negative, urease-producing bacteria. Increase for this malt lymphoma, and it's pretty incredible with these people with malt lymphomas. If you treat the H. pylori, about 70% of the time, the lymphoma will regress completely without need for any, radiation or chemotherapy. There is one translocation that does have poor response to H. pylori and usually requires radiation therapy. But yeah, for the most part, if you have a malt lymphoma, you treat the H. pylori, they get better. And then other than malt lymphoma, just having H. pylori increases your risk for gastrointestinal metaplasia and gastric adenocarcinoma. So you should associate H. pylori with malt lymphoma, but also know that it increases your risk significantly for other gastric cancers. And that's why we are so aggressive in biopsying and testing for it and treating it, just to prevent the gastric intestinal metaplasia and gastric cancer. So as far as treatment options, trying to think of how they would test you on this, because there's so many regimens. The most common, as you know, is triple therapy. So just a PPI, amoxicillin, and clarithromycin. The problem is there is a high clarithromycin resistance rate pretty much across the entire country at this point. So a lot of people are still start with triple therapy, but then have failures, and so they switch to other regimens with fluoroquinolones or other things. Again, I think it would be hard to test you on that because it's really this depends on the specific geography you're practicing and like the resistance patterns in that area. I think the more testable question would be a patient with H. pylori and a pen allergy, what you would do. And then that's pretty simple. You just substitute the amoxicillin for Flagyl, for metronidazole. So triple therapy, they give you a pen allergy, don't give them amoxicillin, just substitute it for metronidazole. That's the UpToDate kind of way and UpToDate has a great, section on H. pylori, just in the future for everyone. That kind of more eloquently describes the issues with resistant rates and things like that. So, they're pushing just for this bismuth quad therapy, maybe right off the bat, if there's local resistance. Otherwise, if they're not pen allergic or not in a resistance area, you could do triple with clarithromycin. Yeah, so that's that. Recurrence of symptoms. So you do want to, everybody you treat for H. pylori, you should treat for eradication. So you test with a breath test or stool antigen after they're off the PPI for 2 weeks. That's very important because if they're on a PPI, it really reduces the sensitivity of the testing. And then if they're positive, still persistently positive, then you would switch to a different regimen that we were using before. So if they were on triple therapy, go up to quad therapy, or what I do personally is this PAL regimen, PPI, amoxicillin, and levofloxacin. And same thing there. If they're pen allergic, just substitute Flagyl for the amoxicillin.
Nick, I have a quick question.
Yeah.
For the follow-up, let's say, I'm not sure if they're going to test us about this specifically or not, but between stool antigen and urea breath test, is there's one of them that's kind of we should use more, or it's from board standpoint? And I know in real life, we mainly do stool antigen, but from kind of board standpoint, what do you think if it can be both options?
And that's a great question. I think it'd be really difficult to test you on that because the studies are, kind of go back and forth. Neither of them are great tests. I think the stool antigen sensitivity is a little higher on average. So that's why, we do usually do the stool antigen. Another reason is just where you're testing. In the hospital, it's easy to order a stool antigen, right? That, the nurses are used to it. They can just collect it and send it off. Bam, it's done. Where we don't even have the breath testing capabilities in the hospital. So you're not really doing it there. Versus in the clinic, I guess maybe some of you already know, it's hard to get a patient to do a stool sample. I mean, it's kind of weird. You poop in this container at home and then keep it in the fridge if you can't take it right away. And So it's not a pleasant thing for patients to be doing at home. So a lot of times as an outpatient, we just do the breath testing because it is comparable. So again, I think it'd be hard to test you on it for practical reasons. I think it really depends on where you're located, but what you're going to do.
Thanks.
Yeah. And then I guess along that note, antibody testing, right? So you can send serum antibodies for H. pylori. And clinically, there's really, we don't use these at all. I've never sent it. But this ID doctor, Dr. Rahman, who put on this board review course that I went to, he said that if you do have a patient that you can't take off PPI because they're bleeding or had a bleeding ulcer, and you're like, oh, well, I know they've completed their 14-day treatment, but I'm not stopping their PPI just so I can test them for H. pylori. You could consider, not for recurrence of symptoms, but just for initial diagnosis, using an antigen and then treating them if it's positive. Again, because it's really not done clinically, and patients with bleeding, we're usually scoping and then biopsying for diagnosis. I think it'd be tough to test on. And then again, in clinical practice, I think the only scenario I can see antibody testing being used is the workup of dyspepsia. And then I think I have a slide on that later on that we'll talk about.
So Nick, if they are positive, if they are positive again and they have recurrence of symptoms, how long do you treat them?
Usually still just 10, 14 days. I think 14 days for the most part. Yeah.
Okay.
And just make sure you're switching up and using, because again, I think you're assuming that whatever organism you had was resistant to something you used initially. So again, if I'm using triple therapy with clarithromycin initially and they're recurrent, I want to make sure it's not like C. diff where you really like push the duration of the antibiotics. It's more switching classes. Again, my preference is a fluoroquinolone, but as long as you're switching classes to something else, that should do it. You don't really have to elongate the course at all.
Thank you.
Yeah. Okay. So other indications other than peptic ulcer disease for H. pylori testing, which I think is, very testable and very relevant from an internal medicine standpoint. So dyspepsia in patients less than 60 with no warning signs. And again, I have another slide on this later, but because if they're greater than 60 with dyspepsia, you go straight to EGD. And I bet they test you on that. If they've had, if they're, like we talked about a little bit before, if they're going to be treated long-term with NSAIDs or aspirin, like you got somebody with myocarditis or something like that, and you're just going to be blasting them with NSAIDs, and you really don't have any other option, you should test them for H. pylori. Unexplained iron deficiency anemia is pretty intuitive. And then I didn't know this until I was preparing for this lecture, but adults with immune thrombocytopenia, there is some literature that treating their H. pylori improves their platelet counts. And I don't think anybody really understands the pathophysiology there, but it was just something interesting that I read. So people with ITP should be tested for H. pylori because treating it could help. It's not going to cure the H, you're still going to need to give these patients steroids and things like that, but it might help a little bit. So briefly on NSAIDs, actually, let me see if I can find my dyspepsia slide since we're talking. Yeah, so just because we've been talking about dyspepsia. Oh, go ahead. Yeah.
I have a question in the meantime. How practical is the urea breath test in terms of testing eradication for H. pylori?
I think it's pretty good. Yeah, I think it's pretty good.
Are you guys using it commonly as an outpatient?
Yeah, commonly. Yeah. And maybe there's you pay for a machine, so we have a machine in our office. I don't think it's a big moneymaker, quite honestly. I'm still a little ignorant to that sort of thing, so I don't know if that plays a role in why we use it more in the clinic. If there is like an economical advantage to doing breath testing in your office versus stool antigen, just kind of being cynical. That's a cynical person. I always think like that, but I think either or, they're both pretty comparable. I think, but for either stool antigen or breath testing, being off PPI for 2 weeks is essential. And then knowing that those aren't perfect tests and sensitivity, and even if they're negative, if they're still symptomatic, considering having them see a GI doctor and considering a repeat EGD just to figure out what's going on is also, reasonable. Again, going along the lines of H. pylori can lead to gastric cancer, so you want to treat it to eradication whenever you can. Does that make sense? Or
Yes.
Okay, good. Yeah, I didn't include any specific studies or anything like that because they're all relatively comparable. There's no hard guidelines, at least from GI guidelines that I know of. I don't know about ID guidelines. I haven't looked at that recently, but as far as the GI guidelines go, it's kind of like either or. Okay, so dyspepsia. So just kind of finish out that thought with the talking about the H. pylori. So dyspepsia is pretty much upper abdominal pain without heartburn. So they're not having regurgitation. They're not telling you, oh, it burns after I eat spicy foods or when I wake up in the morning after I ate a big meal and laid down too quickly at night. It's just kind of non-specific upper abdominal pain. So how do you work that up? And again, this is something that internists can do before they send a GI. So I think it's definitely something you could be tested on. And the guidelines have recently changed in the past 2 to 3 years. It used to be age 50, but now it's age 60. I think it went to 55 before it went to 60. But regardless, if they're 60 years old and they have dyspepsia, regardless of warning signs, they don't have to have the things that we worry about and the things when you're on service, we kind of preach to you to ask every patient: the dysphagia, the adynophagia, weight loss, melena, hematochezia, family history, intractable, vomiting. Those people get EGDs right away. And if they're less than 60, if they have any one of those warning signs above, straight to EGD. But if it's a less than 60-year-old patient with dyspepsia, no warning signs, that's when you would go to H. pylori testing, okay? Even before empiric PPI, which again can be kind of, because if it's GERD symptoms, you would start with a PPI, right? Unless they're, obese, that obese white male over 50, like we talked about. But for dyspepsia, you would want to rule out H. pylori first. And again, fecal antigen, I think, like we talked about, it might be maybe a little bit better in some of the tests, but not all the studies than breath testing. But I think really either or from a test question, they're not going to make you decide to do fecal antigen versus breath testing. But you do one of those. And then again, this is again straight from Dr. Rahman. He said, so if you have a patient with dyspepsia that is already on a PPI, you can do the antibody testing. And if the antibody's positive, that you should just treat those patients. So that's from an ID doctor and a master of the board exam. So again, not something I've ever done in my clinic before, but I think you could imagine a test question where they give you a less than 60-year-old patient with no warning signs and say, what next? And they've been on a PPI for years. And then they give you a breath test to bite on, and they also give you the serology. The patient who's been on PPI should have the serology done and not the breath testing or fecal antigen because they've been on a PPI. Okay.
I just kind of make sure that I kind of got this right. So dyspepsia, the cutoff age is 60, and heartburn, the cutoff age is 50.
Yeah, and I guess for the heartburn, I wouldn't nail down the age as much in your head with the dyspepsia. because with the heartburn, you really need multiple of those risk factors, So if it's just a 55-year-old with GERD, a 55-year-old healthy female, you're not too concerned. I guess if they've had GERD for over 5 years, that would be the more important thing in that scenario versus age. Whereas with dyspepsia, these are very specific guidelines, a very specific algorithm that they could test you on, where the GERD, I think they'd have to paint a more obvious picture with an older obese guy. Where here it's really just the age. That's really the only distinguishing factor. Okay. Okay, so you do the H. pylori testing, and it's positive, you treat them like we talked about before. And then if it's negative, you do empiric PPI for 48 weeks. No improvement with that. That's when you start talking about like low dose amitriptyline at bedtime, or some other tricyclic. And then if still no improvement, then you kind of go down the gastric emptying, gastroparesis pathway. And if they're positive with gastric emptying, you can consider things like Reglan. If their gastric emptying study is normal and they still have early satiety, there's actually been some, recent literature on buspirone, to help with that kind of functional abdominal pain. It works some pathway to increase your gastric accommodation. So it doesn't increase motility per se, but it just makes the fundus of your stomach relax a little bit. So, those functional patients who are very, have this visceral hypersensitivity and can just really sense really small changes in their body. It kind of helps their stomach relax a little bit and gives it a little more stretch, so that they can eat more and have less symptoms. And I have been using this over the past year with some pretty good results. Okay. So back now, where were we? Okay, so NSAIDs. So I guess just so you know, there is Celebrex out there, which is a COX-2 inhibitor, which is better than non-specific NSAIDs as far as a peptic ulcer disease. But in the studies, they did have some CHF issues. So I'm pretty sure it still has a black box warning. I don't know if they've done any further studies recently that took that off, but that you have to be wary in CHF. And then again, I think maybe they could ask a test question about this, but it's not anything we do in clinical practice. You can give misoprostol, which is synthetic prostaglandin E1, in conjunction with NSAIDs to kind of help with that mucosal barrier and to help prevent NSAIDs. And it helps. It definitely helps. The problem is the dosing is like every 4 hours, and everyone gets diarrhea. A lot of people get feverish. It can cause abdominal pain in and of itself. So I bring this up all the time, and in patients, even in the hospital, like, why are we not doing this? Because I've never done it before. I've never seen the complications myself, but all my attendings say, it's not something you can feasibly do. But perhaps you could ask a question on it. Okay, so Zollinger-Ellison syndrome. So this is a gastrin producing neuroendocrine tumor, sometimes found endoscopically, sometimes found imaging. I think the main way they would present is with recurrent duodenal ulcers, or if we're doing endoscopy and we see the vast majority of duodenal ulcers are in the bulb, you think, because that's your stomach acid's going to affect the bulb the most, and by the time it gets through the sweep to your second portion, your pancreas is pushed off in a bicarb that it's really rare to have ulcers in the second portion of the duodenum, or for that matter, further down in the small intestine. So if we see really big duodenal ulcers, or definitely ulcers in the second portion of the duodenum, we usually test for Zollinger-Ellison. However, they can present as a single ulcer, and it can have the prominent rugae like we talked about with Menetriers as well. So the first test would be a fasting gastrin level. So you do that like 0600 in the morning, and the normal's around 50, but if it's greater than 1,000, it's diagnostic. And then if it's elevated, if it's like 300, you can do this IV secretin stimulation test, which, I think they do like asking these next level questions sometimes. Never anything I've done before, but it's pretty much you give them this secretin, which is something, is normally released when acid hits your duodenum and it stimulates bicarb secretion. And it should decrease your gastrin levels in a normal patient. But with these people, it would boost their gastrin again to that over 1,000 mark, and that would be diagnostic. So if they gave you that and said what's next, you could, I think it could go either two ways. If they've already given you where the tumor is, and they're asking like, okay, this is a Zollinger-Ellison patient, we know where the tumor is, what is another test we should check? They're going after PTH. They're going after that association with MEN1. So don't forget about that, because I'm pretty sure I had a test question on that. It wasn't like CDE. It was pretty much remembering that it's associated with MEN1, and they wanted you to check the patient's PTH because they just have such a high association with parathyroid stuff. So if they're trying to get you to localize the tumor and decide between CT, MRI, ultrasound, things like that, there is a specific test. It's like an octreotide scan, which is a somatostatin receptor scintigraphy, that actually will help localize the tumor even if it's really small. And then these patients need resection, and if they get resected, they do quite well. And if they don't, it's not a good outcome usually with all neuroendocrine tumors. I just included this just so you don't you hear me talking about, gastrin normal is 50, greater than 1,000. Like how am I going to remember that? ABIM boards gives you a 12-page test reference ranges, and a lot of times even in the stem they'll give you what's normal. So really you don't stress about remembering what's normal. I would just recommend that as you're starting your studying, maybe print this off and referring to it and being like comfortable with what's on there and what's not. And it's all alphabetical, so it's easy to find stuff. And then just remember things that are abnormal. So they're not gonna have you remember what's normal and everything. They will give you a pretty exhaustive list of reference ranges. So just briefly on upper GI bleeding, it's in practice and in test questions, it's always volume resuscitation first, right? So you want either a central line or 2 18-gauge IVs, and then you want to be aggressive with volume resuscitation. I don't think they would kind of get at like goal hemoglobins like 7 versus 8, because that's kind of controversial. And 7 is for most people. 8, there were studies in the past for patients with ongoing like active cardiac ischemia, they did better with hemoglobins greater than 8. And that's kind of been extrapolated by a lot of people to say anyone with a history of CAD should have a goal greater than 8. Although, I think a lot of people would argue if they're not having an NSTEMI, if they don't have demand ischemia, you could continue a goal of 7. But again, that's pretty controversial. So I don't think they're gonna try to test you on that. And again, I guess just clinical practice wise, I don't think it really matters. If you want to push them to 8, I don't think that's going to hurt them. Obviously, every transfusion is, comes with its own risk of, I'm sure if you've been in ICU, you've seen patients with taco and trolley and immune reactions and things like that. The one I will briefly say, specifically patients with portal hypertension that you're worried about variceal bleeding, try not to overtransfuse those patients. Hemoglobins like 9, 10, definitely over 10 will, increase their portal hypertension and worsen variceal hemorrhage. So, which again, if they're really bleeding and it's mass transfusion protocol, obviously you have bigger things to worry about, right? Than, oh, I don't want to overshoot their hemoglobin to 10. But if it's some, kind of stable-ish cirrhotic who comes in throwing up blood and their hemoglobin 6, but they're hemodynamically stable, and the ER's like, oh, we're going to give them 4 units and a unit. Try to slow that down. I mean, take it a unit as long as they're hemodynamically stable. Try to take it a unit at a time, because you could make the portal hypertension worse. PPI 80 IV loading dose right off the bat is standard of care. Nobody argues about that. So 80 IV, not 40. Drip versus bolus is very controversial, so I won't yammer on about that right now. Just know that it's controversial, and some of us think drips are better than bolus therapy, but they're not going to test you on that. More, and I guess briefly, just because I'm passionate about it, it's more about clot stabilization, and that the half-life of PPIs are very short. So even though there are studies showing that 40 IV BID, the patient outcomes in that study did better, and it was a pretty well performed study. However, just reading about PPIs more and clot stabilization, especially if someone who's unstable and you maybe not being able to EGD them as soon as you'd like, I kind of push to do drips versus bolus, and they will do them. You can order them. You just kind of have to talk to the pharmacy. But I would just, if you have a patient like that you're worried about, just talk to whatever GI fellow's on, and they can help navigate that situation. Okay, and then another thing I think they could test you on is if you've got an unstable patient that's throwing up blood and they're altered at all, intubate them. Just intubate them. I think one of the, when I was in the ICU as a medicine resident, I think that was one of the main, not mistakes, I guess, but I always saw intubation as a failure, as in, I didn't manage the patient well enough initially, and now I'm having to intubate him, and it's a failure. You should not think like that. Think of it as a tool to help, take care of your patients. We intubate patients all the time for elective procedures, and they do just fine. So, if you're on the border about intubate, you probably should be intubating the patient. And again, if they give you an altered patient throwing up blood, they're looking for you to intubate them. Actively bleeding ulcers versus a clean-based ulcer, another thing I think is easily testable. So if you have an actively bleeding ulcer, the patient should be kept in the hospital and observed on IV PPI for at least 72 hours. If you have a clean-based ulcer, you could argue, you could feed that, they come in overnight, we scope them in the morning, or more likely, you've been waiting for us to scope them, we're not doing it until the late afternoon. And then we get it done, and it's just a clean-based ulcer. You can feed them and discharge them same day, just on an oral PPI. So again, from a Choosing Wisely campaign, trying to get patients out of the hospital faster, I could see them trying to test that. Any questions on upper GI bleeding? I guess that I know it's just kind of a brief overview.
Just one question. You know that we are running short of IV Protonics. So what we have is a famotidine H2 blocker.
Yeah.
So is this a difference between Protonics and famotidine in terms of outcome GI bleeding?
Very much so. Yeah, very much so. So if you have a patient who is really actively bleeding, they're throwing up blood, And I'm not talking like, oh, they threw up some black. The nurse told you, oh, it looked kind of black. And so then you extrapolate that to being coffee ground. Bile, if it gets digested, can look black. So, and if they're stable and their hemoglobin stable, you know, I'm talking about real melena, real hematemesis. They need PPI. And if you get pushback from the pharmacy, we can help. We can help with that. Like I'm saying, the GI fellows can help with that. But yes, there is a real difference in, decreasing a patient's gastric pH for clot stabilization, comparing PPI with H2 blocker. Onset of action. Yeah, it's just they're better drugs. Period. End of story. So. If it's a borderline patient just with some epigastric pain and a little melena and maybe per history, but it's not like it's pouring out of them in the ER, and you're admitting them and their hemoglobin's 11 and it was 13 a few months ago, again, in a perfect world, you'd still be giving them a PPI. But I guess, maybe those patients you could just do an H2 blocker if you weren't convinced it was something significant. But yeah, that's a tricky situation. So long story short, yeah, PPI is better. Okay. So cirrhotics, and specifically more just in the setting of bleeding and varices. So all cirrhotics should have screening EGDs every 1 year if they're decompensated, and then every 2 to 3 years if compensated. So, I mean, in the test question, they'll probably give you like a compensated cirrhotic, and they should have like probably every 3 year EGD for varices. Primary prophylaxis with beta blockers is another kind of controversial subject. I think it's testable. You use non-selective beta blockers, especially carvedilol most recently, because there is some alpha adrenergic effects that decrease resistance in your liver, or at least it's theorized that it does. So that's what we've been using, at least in our clinic, and that's what they're using at Henry Ford. Instead of propranolol like they were mostly using in the past. But the problem is most cirrhotics are borderline hypotensive to begin with. And it's ligation is EGDs are pretty low risk procedures, and patients just do better once they're ligated. So clinically, almost all cirrhotics are being, if they have varices, they're being scoped and ligated every 2 to 3 weeks until the varices are eradicated. And at that point, it would be very rare to continue someone on, like, if they've had a bleed before, like a secondary prophylaxis with beta blocker once they've been ligated to eradication. The one exception I've seen is like an older patient with, some terrible COPD or pulmonary issues that are high risk for endoscopy, and they maybe had one EGD several years ago with small varices. I've seen, a handful of patients like that on carvedilol, but for the most part, we're ligating them down to nothing. And if they don't have any, again, from the primary prophylaxis standpoint, it's rarely done, but I could see them testing you on that. So the test question I could see is, you got a cirrhotic, they have a screening EGD for varices, they have small varices. We're no longer grading varices. It used to be grade 1, 2, 3, 4 because of it really doesn't matter how you treat these patients between like grades 2 and 3. It's really either, now they just call them small or large. Small being ones you don't band, and large being ones you do band. So you have a patient that you scope that has small varices, that then they could maybe have you consider they could ask you a question looking for you to pick out the non-selective beta blocker from a bunch of other medications. But again, in clinical practice, it's pretty rare. And then remember asthma, obviously, if they have asthma, you don't want to be giving them non-selective beta blocker. So upper GI, I guess any questions on that? I know.
I have a kind of quick question.
Yeah.
Can you touch base on kind of contraindications to primary and secondary prophylaxis?
Yeah. I think it's really mostly, obviously asthma, you're not going to give them non-selective beta blockers, and then their blood pressure. And then otherwise, it's so controversial. You could argue, and I have not argued, but I brought it up, these patients with small varices to have, nobody's really doing it for primary prophylaxis. I guess I'll start with that in clinical practice. The guidelines would argue differently, but in clinical practice, nobody's doing that because they worry about hypertension and things like that. Secondary prophylaxis is really the only time I've seen it done for small varices. And that's even when you're asking, because we go to Henry Ford for transplant hepatology, and I make it a point to ask them, each specific hepatologist, work with how they approach this. And, they usually get frustrated and tell me, oh, it's complicated and controversial. But yeah, for the most part, yeah, it's really just for secondary prophylaxis and someone with small varices that you're worried about having to repeat EGDs on because they have complications. But from a test question, they could ask you primary prophylaxis to start low dose carvedilol, and that would be the right answer. Yeah. So sorry again. I know that's confusing and nebulous, and that's not just you feeling like that with me. That's how I feel when I ask any of my attendings or anybody at Henry Ford. So it's really, unfortunately, not any clear guidelines or pathways for that. Okay, so upper GI bleeds and cirrhotics. So ceftriaxone, definitely something they could ask you about, regardless if they have an history of SBP, regardless of their acidic fluid studies, which again are neutrophils greater than 250. So not white blood cells, neutrophils specifically. You start ceftriaxone if they're bleeding, right? Even if you're concerned that they're bleeding, yeah, you start ceftriaxone empirically. I get asked about duration all the time. It's unless you have studies showing SBP, which the problem is you're usually starting ceftriaxone right off the bat, and then you're doing the paracentesis a day or two down the line. So they've been on ceftriaxone for 2 days, so if they had SBP to begin with, you're not going to know, which is problematic from the standpoint that some of these patients with SBP, there is literature supporting prophylactic antibiotics like Monday, Wednesday, Friday Bactrim to prevent SBP. So we're trying to get a study going with the ER physicians of, tapping these patients before, almost like blood cultures, like tapping them before you start antibiotics empirically. So maybe, we might have a study up and off the ground here soon looking at that. But so all in all, for duration, it's usually just when they're hospitalized, you give it to them for a few days. And once we get the GI bleeding under control, you're not really discharging them on like a 7 or 10 or 14-day course of antibiotics. Usually it's a couple days. And again, that could be if you did do a tap and it grew out some pathogen, like on culture, then that's a little different scenario. You probably want to treat that for 5 or 7 days with antibiotics specific to that bacteria. But just in general, the way it usually plays out, you just give it for a few days while they're in the hospital. Octreotide, I get calls all the time where, oh, it's a cirrhotic, their hemoglobin's a little lower, maybe some melena. They're hemodynamically stable. I usually just I start octreotide regardless initially, just right off the bat. It's not going to hurt them. And if they do have some variceal hemorrhage that's slowed down at, even before they came to the hospital, it'll help with the portal hypertension and preventing them from decompensating. And then once we scope them, then we can decide whether to stop it or not, or once we see them the next day. And then always remember, with these cirrhotics, don't get hung up on just variceal bleeding. 30% of the patients have peptic ulcer disease on endoscopy, so always load them up with that 80 IV of PPI. And recurrent variceal bleeding and a MELD less than 14 and no hepatic encephalopathy. If they gave you a patient like that, they're probably trying to get after TIPS. So I think the important things there are the MELD less than 14 and hepatic encephalopathy. The MELD score was originally designed to help risk stratify patients who should and should not have TIPS. The idea being, so your liver and cirrhosis is scarred down and you get this portal hypertension from all the blood trying to find ways, around, back to your heart. And, but you still have some liver function in that fibrotic tissue. So if you take a good sized stent and drill it through your liver so it bypasses a lot of your liver, whatever function you did get from that part that you're bypassing is gone now. So if your MELDs are already high and then you bypass the remaining functioning liver that you had, you're not going to do well. And especially with hepatic encephalopathy, if patients have hepatic encephalopathy before they get a TIPS, it's terrible once you bypass a lot of their remaining functioning liver. So, but if their MELD's low and no hepatic encephalopathy TIPS, and then if their MELD's high, and they give you an option to transfer, you should just transfer them to a transplant center.
Oh, I kind of have a question about beta blockers again. I just remember.
Yeah.
So, let's say they give you a patient primary prophylaxis and the patient is already a non-selective beta blocker. Isn't it like if they have SBP or they have bad ascites, it's contraindicated to give them the beta blocker? Is that still a thing? Last time I remember studying for step 2 a couple of years back, but I'm not sure if that's in the guidelines, if there's actual such thing or no.
No, you're right. It's just, I don't think having SB, you can nail down to that the beta blocker is making it that much worse. So I don't know if that would ever change how you treat. There is literature on that, but so maybe if you had a patient who had really bad ascites to start and you were trying to decide whether or not to start them on primary prophylaxis, that would push you away from that. But I've never seen it before where you would take someone off a beta blocker just because of SBP or recurrent ascites. And that could be something I don't know though. So that could be literature or guidelines that I am not aware of and that I just haven't seen when I'm at Henry Ford and I don't know of. So don't take my word on that. You could be onto something there that I just don't know. Okay.
Sounds good. Thanks.
I'll read about that. No. Again, but it's so frustrating when you try to read about these beta blockers, and it's one of the most frustrating things I've encountered so far in my fellowship, because it makes all the sense in the world to have these patients on it, and there's data to support it, but then when you try to bring it up with any attending, they're like, no, So which I'm sure never happens to you guys, when you're practicing. Okay, so so that's pretty much it for that. Any other, questions while we're breaking? Okay, all right, here's a test question for sure. So you got a patient who comes in with bleeding and has isolated gastric varices on endoscopy. What's the next best test? they're looking at this splenic vein thrombosis, right? So if you get isolated splenic vein thrombosis, you can get, and I guess it doesn't have to be isolated, any thrombosis, including your splenic vein, it can cause these isolated gastric varices, usually kind of not, because you can get gastric varices obviously just with your run-of-the-mill cirrhosis, but they're almost always associated with esophageal varices. But if you have isolated gastric varices, that is very, very suspicious for splenic vein thrombosis. And I've seen this in, I've seen this in real life too, so it's clinically relevant. Definitely more common in your chronic pancreatitis patients, but they could give you a stem that just has, a patient's otherwise healthy, except, drinks here and there, and had, to try to, kind of get you down the cirrhotic pathway in your thinking of workup. But they're not really cirrhotic. It was just they had some acute pancreatitis or something like that. So just store that away, because I think it's very, very high yield. Okay, we talked about dyspepsia, dumping syndrome. Maybe they could ask you some questions on that, just because it's, again, something easy to manage without medication. So somebody eats and then they short postprandial, like 15 to 30 minutes, they get palpitations, diaphoresis. They have this postprandial dumping syndrome, and you just have to bump their fiber and their protein. Complex carbohydrates help too, but really the fiber and the protein is most important. Again, idea being you're trying to slow their gastric emptying a little bit, so not all of that nutrition is hitting their duodenum and kind of diverting blood flow to your enteric system and things like that right away. And so if you remember that, then you can also kind of remember the treatment for gastroparesis is, I guess gastroparesis is also high protein, but it's low fiber, more liquid, things that, increase your gastric emptying. And then, yeah, if the symptoms are more delayed, like 90 minutes, think those patients are ones with gastroparesis, and their food's sitting in their stomach and they're getting hypoglycemic because nothing's emptying into their small intestine. So low fiber, small meals, mostly liquid. And then you always want to, before you jump to Reglan, and because of all the side effects associated with that, they're definitely going to want you to try this lifestyle modification, which again is tough in real life, but it does help if they can be compliant to that kind of diet. Where are we at? SIBO. All right, we'll talk about SIBO and then we'll be done. So SIBO, patients with any sort of small bowel surgery are at increased risk. Just thinking, when you alter their anatomy, their motility is probably not going to be the best, and they have like little. Usually when you hook people back up, there's little pouches here and there from, side to side or end to side anastomoses where the bacteria can hang out and proliferate. Somebody who has been scoped before and has had small bowel diverticulum or diabetics, those people are all at increased risk for this SIBO, or small intestinal bacterial overgrowth, where you get deconjugation of your bile salts by the bacteria, which then causes a fat malabsorption, kind of diarrhea and steatorrhea. The test for this, we can either do, technically gold standards like duodenal aspirates or things like that. We don't do those in real life. But you can do breath testing, specifically, for your, usually they use glucose or fructose. That's another controversial thing, which is better between those two. But to pretty much test the breakdown of that, and you have to have a certain elevation in parts per million from a baseline level. Again, I don't think they get you into the specifics of that. The low B12 high folate is something I think that they do like to test. So try to store that away in somebody with, diarrhea, and then they give you low B12 high folate. That's pretty indicative of SIBO, because The B12 is is from the malabsorption, and then the high folate is because the bacteria makes the folate. And then you treat with rifaximin.
Hey, Nick, do we have hydrogen breath testing here at Sparrow?
I do not believe so. No. Yeah, but we do at MGI. And I've been doing it a lot with functional patients, especially with bloating, because there's new guidelines that if you read them, it's pretty much any patient you have ever seen with abdominal pain could meet criteria for breath testing. The other thing we've been doing a lot is just treating empirically because rifaximin has a new, it's actually easier to get rifaximin paid for by insurance companies, giving them a longer, higher dose, so 550 3 times a day for 21 days for IBS diarrhea subtype. Like that's easy to get insurance to cover versus if you have a positive breath test for SIBO, a lot of insurance companies won't cover rifaximin, even though it's a lower dose 550 BID for 14 days. So go figure. But so one of the things we've been doing now is if we're suspicious of it, just going straight ahead with treating with rifaximin. I mean, I usually still just do 550 BID. Just tell them they're going to give you more medication than you need. You don't need to take all that. But yeah, if you're having trouble getting someone breath tested, maybe just consider doing that.
Thanks.
Yeah. All right. I think we're getting pretty close to time. Yeah, I'm almost over my time.